Tantor Audio, a division of Recorded Books, presents Trauma Made Simple: Competencies in Assessment, Treatment, and Working with Survivors. By Jamie Marich, Ph.D., LPCCS, LICDC, CS. Narrated by Emily Durante. Chapter 1. Trauma Matters. The wound is the place where the light enters you. Rumi. Defining trauma. No topic of social importance was off limits to the late American comic George Carlin, including the psychiatric diagnosis of post-traumatic stress disorder. In one of his most famous rants, Euphemisms, from Doin' It Again, 1990, Carlin presented the evolution of how the psychiatric profession described trauma over the course of the 20th century. In World War I, combat trauma was called shell shock. Carlin mused that its two syllables, simple, honest, direct language, sounded like a piercing bullet. Then the Second World War ushered in the term battle fatigue, 4 syllables, and softer in Carlin's view. Next came the Korean War, when the term operational exhaustion prevailed, and as Carlin posited, with more syllables came less humanity. Finally, in the aftermath of Vietnam, the term post-traumatic stress disorder, our current label, emerged. As Carlin quipped, we now have 8 syllables, a hyphen, and an even more sterilized, clinical-sounding diagnosis. In perhaps the most brilliant commentary on modern psychiatry and psychology, Carlin declared, "The pain is completely buried under jargon. I'll betcha if we'd still be calling it shell shock, some of those Vietnam veterans might have gotten the attention they needed at the time." As a clinical counselor specializing in the treatment of trauma and stressor-related disorders, I agree with George Carlin. In our attempts to be clinically savvy and medically relevant, we have lost the human touch when it comes to healing wounds. In its simplest form, that's what trauma is, a wound. The English word trauma is a direct translation of the Greek word for wound. 1 syllable, simple. The past 2 decades witnessed increased interest in traumatic stress research. Trainings on PTSD proliferated. Multiple organizations came into existence or expanded to address trauma, and clinicians reached out to those in need of care. Yet so many human service professionals are more lost than ever when it comes to trauma and how to treat it. A central thesis of this book is that the helping professions continue to overcomplicate how we conceptualize and treat trauma. Perhaps we need to go back to the word origin basics for enhanced insight into understanding and healing emotional trauma. Consider everything that your human experience teaches you about physical wounds and how they heal. Wounds come in a variety of shapes and sizes, resulting from various causes. While some are more serious than others, most wounds require care to heal. A gunshot wound will necessitate a trip to the hospital and may be fatal, especially if proper care is not administered. In contrast, a scrape may require only a simple washing and bandaging. Yet with proper care and rehabilitation, the gunshot wound survivor may be well on his or her way to health, while the person with an unattended scrape could experience repeated infections. Wounds can happen quickly and take a very long time to heal. However, if conditions are right, a person can recover from or at least adapt to an injury and lead a relatively full life. Some people are in a better position to heal than others. Perhaps they have access to superior care. Maybe they are given adequate time off from work to recuperate, compared to others who do not receive such accommodation. There are differences in genetics and constitution. For example, a simple scrape on a hemophiliac or someone with vulnerabilities to infection requires a higher level of care. Sometimes the proverbial X factor in healing is attitude. Consider how a person who believes, "I am weak," might fare compared with the person who can accept that, "I am only human, accidents happen." Our society encourages us to continue working and navigating daily life while injured. We praise athletes who can muddle through injury, and when we are hurt, we may tell ourselves, it's just a sprain, it's no big deal. We, like the athletes we admire, may be able to push through the pain. We learn that we can't baby every little injury or sickness. While there may be some truth to this logic, many of us too deeply internalize these tough-it-out scripts and ignore the legitimate warning signs of physical or emotional injury. We ignore our body's cues and cries for help. Like the Black Knight in Monty Python and the Holy Grail, we protest, it's just a flesh wound, when in reality, we're in bad shape, or in the case of the Black Knight, all of our limbs are falling off. Veteran psychologist Dr. John Hoover, a trauma expert and retired Marine, renders a useful distinction between being hurt and being injured using the metaphor of a football game. During almost every football game, play will be stopped if a player lying on the ground hurt is being attended to by the trainer. The announcer is likely to comment that the trainer is determining whether there is an injury to the player or if the player is just hurt. Injury is defined essentially in physical terms, such as a break, tear, separation, sprain, whereas hurt refers essentially to pain. If the player does not have an injury, after waiting one play, he can return to the field of play even if he still feels pain. If the player does have an injury, he will not likely be cleared to play again until the injury has healed. Thus the phrase, you can play the game hurt, but not injured. Life is like a football game. Because life can be very traumatic, pain is inevitable, and it would not be feasible to stop life every time we got bumped. Like Hoover explains, learning the distinction between hurt and injured, and knowing how to honor our need for care when we are injured, are paramount. In worst-case scenarios, especially in evaluating injuries that lead to permanent disability, total healing is not biologically realistic. Consider Heather Bowser, a woman whose story I will be telling throughout the book. Heather was born in 1972 with only one leg and severe deformities of both hands. Injuries attributed to her father's exposure to Agent Orange during his Army service in South Vietnam. While Heather's gestational injuries are permanent in the medical sense, her ability to adapt to her condition is nothing short of exemplary. A successful counselor, business owner, wife, mother, and advocate for victims of Agent Orange exposure and children of Vietnam veterans, Heather proves that even with grave, irreversible physical injury, it is possible to live a full and healthy life. That is the power of adaptation and resilience. The human brain is hardwired for healing in both a physical and emotional sense. However, quality of the healing conditions can make all of the difference. If a person is given the resources he or she needs for healing, for example, time, social support, validation, proper care, spiritual guidance, emotional wounds can be healed. As with physical wounding, there may be scars, but if that emotional wound is given proper attention, the part that was hurt can become tougher, just like the skin of a physical scar, a beautiful metaphor for resilience. I have spent years experiencing trauma, healing from it, helping others heal from it, writing about it, and teaching about it. Informed by these experiences, I contend that the wound concept is the simplest way to conceptualize trauma. Let's keep it simple. Trauma means wound. If you want to delve into a more nuanced translation of the Greek word traumatikos, it means a physical injury that is capable of being closed up. Think back to the time in your life when you felt the most wounded, either physically or emotionally. What did you need to heal? Being a trauma-sensitive professional and human being is, above all, about acknowledging and honoring woundedness. If the parallels between physical and emotional wounding resonate, this book will make total sense to you. The wound is the main motif of the book, and we consider its healing lessons throughout. The title of the book is not meant to suggest that there is anything simple about traumatic stress and how it can wreak havoc on the human experience. On the contrary, The after effects of trauma can entangle survivors in a complex web of distress and complicated living. Untangling these webs can be a very involved process that is anything but simple. However, the title is meant to suggest that as helping professionals, we overcomplicate the study of trauma. It seems that every month someone comes out with a new model or paradigm for treating trauma. While advances in neuroscience continue to give us cutting-edge information on how trauma affects the brain, I see little to suggest that these scientific advances and their dissemination are producing more trauma-competent therapists. Consider this metaphor. You can know everything about how a car works, the intricacies, the mechanics, the operations, but at the end of the day, do you know how to drive a car? More importantly, does your technical knowledge of the car help you drive more effectively in treacherous circumstances? If the answer is yes, that's great. My belief is that experience with working the car and navigating the roads of life is what makes you a skilled driver, not your knowledge of the car itself. Similarly, when scientific or philosophical knowledge takes humanity out of the equation or minimizes the vital role of experience in applying that knowledge, the knowledge fails to be useful. In 2011, I wrote a book called EMDR Made Simple: 4 Approaches for Using EMDR with Every Client. My contention is that many people get tripped up with learning and implementing eye movement desensitization and reprocessing, EMDR therapy, a popular modality in treating traumatic stress, because they overcomplicate it. I feel the same way about trauma treatment in general, and I carry that same spirit of less is more into this book. I have long embraced the wisdom of Occam's razor that all things being equal, the simplest explanation tends to be the right one, even with something as complicated as trauma. Trauma is wounding. Wounds need care and time to heal. A little common sense and human connection go a long way in helping wounded people heal. Trauma is a subjective human experience, colored by an individual's perception, life experience, and healing style. My general assumption is that if an experience is wounding to a person, we should validate it as traumatic. This approach, what I call broadening the definition of trauma, is not without controversy. Many people I've trained and professionals with whom I work get nervous when we start talking about trauma as more than just diagnosable PTSD. As one mentioned, well, if we say that everything can count as trauma, aren't we impugning what people who go through really major stuff, like wars and genocide, experience? I mean, so much of these other things, like divorce and bullying and losing a job, are just life. Deal with it. My answer to this sort of comment is that life, on the whole, is traumatic. Trauma affects some people more than it affects others. Just like there are various types and styles of physical wounds, so too are there different manifestations of emotional traumas. Expanding the clinical scope of trauma to include all human wounding is not meant to minimize the types of life-threatening trauma that may qualify for a PTSD diagnosis. Being trauma-informed or trauma-sensitive, I use the terms interchangeably throughout the book, is about recognizing that all wounds deserve attention. Being able to appreciate the subjective nature of wounding and healing is a core component of being trauma-informed, and it will help us to be more effective in the delivery of clinical and community-based services. In their own words. When I give trainings on trauma, I challenge participants to take a few minutes to jot down their working definitions of trauma coming into the workshop. I inevitably find that no two people give me the exact same definition or wording, which is to be expected when we consider how subjective trauma really is. How would you respond if you were asked, what does trauma mean to you? Some people describe a very specific incident, like the death of a loved one, 9/11, or a life-changing injury that, in their view, represents trauma. However, others give a more general or global definition, some of which are worth sharing. Donna. Trauma means feeling horrible in response to someone or some situation that totally overpowers me. Trauma is like riding my bike and the chain falls off. I can't get away. Karen. Trauma is living with the aftermath of neglect, physical, mental, emotional, sexual abuse, abandonment, rapes, domestic violence, betrayals. Vicky. Trauma means a wound that is either inflicted or perceived, which affects either the body or spirit. Jim. Trauma dries you out. It takes all of the natural oil and flexibility out of you so you can't bend with life. That's why traumatized people are so defensive. They are so afraid someone can break them at any time. Nadia. An event that alters the course of your life forever. A reoccurring nightmare that you have to strive to overcome. Rena. Trauma is reoccurring fear, paralyzing panic, guilt, shame, based on past life experiences, pre-programmed childhood upbringing. Holly. Something that has shaken your inner core so badly you have to work through it. Patty. I've always viewed trauma as a weakness, not a wound, which is part of why I hated the word trauma so much. My therapist helped me redefine my definition. Colleen. An injury due to a stressful event, affecting body, mind, spirit. I think most Native Americans would also define it as lack of integration from spirit. Kathleen. Trauma and loss, for me, are interchangeable. Joseph. Hell. Carla. Hell on earth. About this book. Throughout this book, I share many stories and first-person accounts. Some stories are my own, both personal and clinical. Others I cite from the literature and from the direct words of people who agreed to contribute their experience, strength, and hope to this project. The contributors and their experiences are major informants to this overall work. Some of the voices are friends, others are former clients and colleagues, and others are people who read about the Trauma Made Simple project online and agreed to participate for the sake of educating others. In some cases, former clients or contributors did not wish to be named. When I use a pseudonym, I indicate this with an asterisk. Rest assured, this book addresses issues of technical importance to clinical practice, for example, diagnosis, treatment planning, billing, agency logistics. However, the experiences of real people are included throughout the book to infuse humanity into the subject matter at hand. Encountering the lived experiences of trauma and recovery is, in my opinion, the best way to learn about trauma and how to treat it. As a clinician and an educator, I fully embrace the wisdom of poet and activist Muriel Rukeyser, 1913 to 1980. The universe is made of stories, not atoms. I wrote this book primarily for a professional audience, social workers, counselors, psychologists, medical doctors, nurses, marriage and family therapists, pastoral counselors, and case managers. This book is not intended to teach you how to reinvent the wheel of your practice, but hopefully it will help you become more trauma-sensitive in your day-to-day operations. If you already consider yourself to be a trauma-informed professional, I hope this book serves as an affirmation for you. You might be able to take some ideas from the book and blend them with your existing approaches. Those who work in tandem with helping professionals are also likely to benefit from this book. For instance, 12-step recovery sponsors, wellness providers, for example, nutritionists, body workers, yoga or fitness instructors, teachers, and administrators. You are an important part of a client's world, and being trauma-informed as a global precaution for all human services is optimal. This book is not meant to be a substitute for professional training, so if at any time you are listening to a concept and are unclear about its meaning or appropriateness of application, seek guidance from a clinical professional within your network. Because I strive to write in user-friendly language, there is a chance that you, the survivors of trauma, may be picking up this book to better understand what's going on with you. if you are in this boat, go for it. We can all stand to educate ourselves on what ails us. However, I strongly advise that you not use this book to replace professional diagnosis and treatment. Only a licensed professional in your state can provide these services. If you are not currently under care and the concepts in this book are resonating with you strongly, I encourage you to pursue professional help. Seeking such help doesn't make you sick or flawed. It simply means that you are open to the assistance that might be out there for you. If at any time you feel like material in this book is too much to handle emotionally, put it down and engage in an activity you know will help you to distract in a healthy way. For example, a hot bath, a cool shower, a brisk walk, prayer, playing with your pet, word puzzles, knitting, calling a trusted friend. If you experience an acute psychiatric emergency, that is, you feel like harming yourself or someone else, please call 911 or seek help in your local emergency department immediately. My disclaimer about self-care applies to all of us, professionals, paraprofessionals, and lay people alike. Hearing about trauma can be an intense, even triggering experience. Thus, if at any time your body's internal cues tell you that you need to put the book down for a while, honor that. Finishing a book is not a race. Listening to this material provides a chance to practice honoring your internal cues and treating yourself with kindness and compassion. Chapters 2 through 4 continue to build on the foundation laid in this opening chapter. In Chapter 2, the new DSM-5 category of trauma and stressor-related disorders, including updates to the DSM-5 diagnosis of PTSD, is thoroughly explained. These diagnoses are discussed with consideration to biopsychosocial spiritual elements. In Chapter 3, we consider how grief and loss can be conceptualized as trauma, explain the constructs of grief, bereavement, and mourning, and discuss the broader definition of trauma. Chapter 4 presents the basics of trauma neurology that are most relevant to clinicians. Chapters 5 through 7 cover important issues regarding assessment and treatment planning. Chapter 5 covers a variety of assessment strategies, quantitative and qualitative, direct and subtle. It is the hope that this chapter will allow professionals in clinical settings to know trauma or grief when they see it and develop an initial plan of action. Chapter 6, the addiction imperative, is included because the comorbidity between trauma-related disorders and addictive disorders is so high. In this chapter, listeners get a brief orientation to addiction and how to assess for it, especially when trauma-related disorders are also present. Chapter 6 also helps clinicians develop an initial plan of action for addressing addiction. Chapter 7 examines how empathy and the therapeutic alliance can be established from the first session. The quality of empathy is essential in working with clients on trauma. In this chapter, strategies for building empathy with a client, even very difficult ones, are explored. Chapter 8 explores the consensus model of trauma treatment and its 3 stages: stabilization, reprocessing, and reintegration. The 3-stage consensus model can be universally implied, regardless of a clinician's therapeutic or theoretical orientation, and it serves as an effective framework for healing trauma. Chapter 9 covers the first stage, stabilization, in greater depth, with chapters 10 and 11, respectively, delving into reprocessing and reintegration. Chapter 12 is the ultimate wrap-up, challenging you to consider what you absorbed by evaluating what makes a good trauma therapist. The chapter delves into what professionals need to effectively work with trauma in clinical and community settings. Issues of self-care, self-awareness, and personal and professional competencies are explored in depth. Chapter 2, Diagnosing Trauma, DSM-5 and Beyond. If we can make the correct diagnosis, the healing can begin. If we can't, both our personal health and our economy are doomed. Dr. Andrew Weil. On diagnosis. After 2 years of working as an English teacher and humanitarian aid volunteer in post-war Bosnia-Herzegovina, my mentors suggested that I return to graduate school for counseling. I looked at the admissions brochure from the small Catholic university in the United States with ties to my parish in Bosnia-Herzegovina. There was a stack of books on the front of the brochure, artistically staggered texts with titles like Developmental Psychology and Counseling for the Modern World. One book was thicker than them all, and the spine read, Diagnostic and Statistical Manual of Mental Disorders 4-TR, DSM-4. I remember telling myself, I don't know if I can do this. I learned not to fear the scary tome from the brochure picture, and even though I didn't agree with some of it, I learned how to use it. After all, using it was a necessity in the hospitals and treatment centers where I completed my internships. My larger frustration was with meeting professionals who, in my view, misused the DSM-4, or at very least, misinterpreted diagnoses. Even at my first clinical internship site, the evidence of unresolved emotional trauma was so apparent in the children and adolescents we treated. The irritability and emotional reactivity they demonstrated, especially when they felt cornered by staff, were all too familiar. Yet the psychiatrists seemed to know only one diagnosis, bipolar disorder. When I transitioned to my second internship site, a drug and alcohol facility, I was told I didn't have to worry about mental health diagnoses when I assessed patients, even though several clearly met criteria for PTSD. Diagnosis in the treatment of mental and emotional problems is controversial territory. Even the chair of the DSM-4 task force, Alan Francis, MD, believes the helping professions have gone too far in pathologizing the ordinary stresses of human life. I generally support the position of psychiatric legend Irvin Yalom, MD, who believes that diagnosis is only really needed to get a patient's treatment to be paid for by third parties. There are so many people in my professional circles, especially expressive therapists and humanistic psychologists, who are adamantly opposed to diagnosis on moral grounds. They have especially raged against the new edition of the DSM, the DSM-5, with vehemence. When I submitted an article to one expressive arts publication, the editor responded that he liked what I had to say overall, but he couldn't get past me using labels like PTSD or disorder. On one hand, I see his point. It would be fantastic if we saw only the person and not the diagnosis. But on the other hand, I have spent my career working in settings where I must diagnose in order to justify treatment and bill insurance companies or the government entities sponsoring treatment. Good luck working in an agency without using diagnosis. I refrain from obsessing over diagnosis. If you're frustrated at me for already getting into heavy material on the DSM, especially in a book that claims to make something simple, I actually feel your pain. I want the focus to be on the person and not his or her illness, but diagnosing is a necessary evil in American clinical culture. Even the great humanists among us have to play the game, depending on where we work. Moreover, there are some contexts in which learning about one's diagnosis can be useful and even empowering. Consider those individuals presenting for treatment believing that they are just crazy or nuts. While labeling can, no doubt, be stigmatizing for some, for others, it can be a relief to hear that their troubled behavior can be explained. I do not advocate using a diagnosis as an excuse for poor behavior. For example, I go off on my children because they trigger me. The PTSD makes me do it. When clients say this to me, I challenge them with, okay, so it's the PTSD. What can we do to help you with it? For other clients misdiagnosed or over-medicated by previous providers, learning about PTSD as an explanation of their behavior can be life-changing. Consider Helen, referred to me for a trauma assessment after 2.5 years of largely unsuccessful hospitalizations, group treatments, and individual sessions with a variety of therapists. All previous providers labeled her as bipolar because of her moodiness, lashing out, and intermittent suicidal ideation. Yet after 10 minutes of sharing, it was so clear to me that Helen, in her early 30s,
Sample complete. Ready to continue?